Hello everyone. When I was in the OPD yesterday, I saw a case that a 39-year-old male, he came to my OPD and he is complaining of itching over his right nostril since 3 days. Okay, he is not any comorbid case, only hypertension, diabetes or something. So when I looked back, I noticed a small blistering bulle. Okay, over the nose here. Yes, I have seen that bulle here, and I see some honey-colored crust over the honey-colored crust I have seen noticed. This is the patient, and you can see that this erythematous base is very important. Yes, I have noticed that erythematous base. But yes, when I looked to it clearly, I have seen that the crust is clearly seen honey-colored and polycyclic plaques. Yes, I have come to the diagnosis of a superficial localized non-follicular pyoderma, and that is impetigo contagiosum. Okay, impetigo contagiosum. That's a diagnosis. Yes, how we came to the diagnosis. We know that some description about this impetigo contagiosum. What does what causes this impetigo contagiosum? The gram-positive organisms like Staph aureus and Strep pyogenes. What is the epidemiology? It occurs in preschool students, okay, and young school children. And what are the clinical features? We should remember that the clinical features are thin-walled bullae with an erythematous halo, rupture, rapidly to form an exudative plaque covered with thick honey-colored crust. Of course, we have seen this is the honey-colored crust. Okay, honey-colored crust. Remember this. Okay, and the lesions may be coalescing together to form the polycyclic plaque. Polycyclic plaque. Okay, the site of predilection mostly in the periorifacial area and the nose and scalp, face. Association is a regional lymphadenopathy. If there is a regional lymphadenopathy, it is a bit, we could say it is a bit severe lesion or severe problem. Okay. The complication is eczematization, which means that lesion superficially move into the deep tissue, which forming eczema. Then if it is acute post-streptococcal glomerulonephritis, this is the one complication occurring about 25%. Okay. I have seen yesterday a 12-year-old boy came into a OPD. He had some lesion over his hands and legs, a pyodermic lesion, and his creatinine value was 3.5. So I noticed that it's a pyoderma with renal impairment. Okay, it's a glomerulonephritis. Mostly it could be a post-streptococcal. Okay, but don't worry, the strains we should remember that the type M49 strains are the nephrogenic strains. These are the most notorious strains of Streptococcus, which can cause glomerulonephritis. The diagnosis is if it is a child, if you see these told characteristics in a child, you diagnose it as a impetigo. And most important point is honey-colored crust because in other diseases, in herpes disease as well as in bullous impetigo, can also see some these lesions or similar lesions as well as crust, but the color is different. Okay, the staining that we use is gram staining, and we can also go for culture. The DD in bullous impetigo, there is no erythematous base, varnished color, and there is an annular lesion. Bullous impetigo, you see here that they are annular lesions and varnish colored. Then come to the another diagnosis, herpes simplex virus. In herpes simplex, there are grouped vesicles around the mouth. Okay, see, this is a case of herpes simplex. You can clearly see that these are mostly over the lips or around the periorifacial area. See, this is the oral herpes, mostly over the lips. The site is different compared to impetigo. So that is a differential diagnosis. Okay. Next comes the treatment. General measure, you make it dirt free or make it hygiene. That you hand wash so that it not spread. Like a local hygiene, you clean with soap and water and remove the crust without causing any damage or any pinpoint bleeding. The specific treatment that we give here is topical treatments. Okay, the topical antibiotics or mupirocins or fusidic acid can be given. Then we can give systemic treatments like azithromycin, which cover gram-positive. If it is resistant, you can go for amoxiclav, 25 to 50 milligram per kg per day, or we can use a beta-lactamase inhibitor like cephalexin, 50 milligram per kg per day. These are the treatment modalities. The systemic treatments are required only if the lesions are extensive, like what you said, eczema lesion, or if there is a regional lymphadenopathy. In such case only, or any complications are going for. In such case only, such treatments are required. Okay. Thank you. Have a nice day.